an article written by Harvey Risch, who is a professor of epidemiology, Yale School of Public Health, author of over 300 peer-reviewed publications. And he writes in part, "I'm usually accustomed to advocating for positions within the mainstream of medicine. So I've been flummoxed to find that in the midst of a crisis, I'm fighting for a treatment that the data fully support, but which, for reasons having nothing to do with a correct understanding of the science, has been pushed to the sidelines. As a result, tens of thousands of patients with COVID-19 are dying unnecessarily. Fortunately, the situation can be reversed easily and quickly." Professor Risch, how are you, sir?
I'm good. Nice to be here.
The question is, you've looked, I take it, at all these studies, and what do you conclude?
I conclude the evidence is overwhelming. There's no question that in the people who need to be treated and are treated early, it has a very substantial benefit in reducing risk of hospitalization or mortality. And there's been a massive disinformation campaign that stretches from the government to the media that's either suppressing this message or it's countering it with a false message. And I'm not an expert in the reasons why that's happening other than just observing it, but I am an expert in the science, and I can tell you the science is all one-sided. In fact, the science is so one-sided in supporting this result that it's stronger than anything else I've ever studied in my entire career. The evidence in favor of hydroxychloroquine benefit in high-risk patients treated early as outpatients is stronger than anything else I've ever studied. So scientifically, there's no question whatsoever.
Doctor, I want to ask you this question. People with heart disease or asthma, are they likely to die or have a certain type of critical reaction to this drug?
No. The evidence is that healthy people with heart disease generally do fine on this medication, but like any medications, they should be prescribed by a doctor who's actually following the patient, knows what to expect, and is able to monitor it. And all medications should be used that way, and this is no different. But in general, this is a very safe medication. The medication itself has, in some people, perhaps 10% of normal people, can change the pacing of the heart muscle contractions, called the heart rhythm. That change has only measurement value. In other words, if you measure it on an electrocardiogram, you can see it. It has essentially no bearing for almost everyone who has that as to any risks for a real arrhythmia that has potentially life-threatening consequences. It is a very, very, very low risk.
You know, again, as a pedestrian, no expert, but I read the various reports, I read what you write, and I draw my own conclusions from this. It is incredible to me that in the middle of this pandemic, that a drug that has been used for over half a century, where the testing has been so thorough and it's been ubiquitous, and it's so cheap, each pill is very, very cheap, that there is this effort to fight it and to destroy the doctors and the experts who dare to suggest that in the early stages, or even maybe as a prophylactic, you might want to use this if it's prescribed by a doctor. Now pharmacists are afraid to provide it. And now doctors are concerned to prescribe it. And some hospitals won't prescribe it. And this has been politicized in an incredible, incredible way. And you write here, wait a minute, this drug can save thousands and thousands of lives. Have you ever seen anything like this?
Never. Somehow we've let politics overrule science. And it's an absurd situation. People have compared this to 1984 and the Ministry of Truth and so on. That's limiting what people can say on objective facts. It's beyond belief.
And I watch when you do interviews on other networks, these so-called news hosts are literally angry at you. They're shouting you down. They're interrupting you. They won't even let you make your case. That seems a little odd too, doesn't it?
Well, here's the thing. I think they know that the treatment works. I think that basically they're afraid to even let it be tried, because letting it be tried would show that it works. So the message has to be shut at all costs, because anything will leak out. And in fact, it is leaking out. And you see across the country people who started to speak up, who've become almost deathly ill and have been turned around in 3 days or sooner even. And these are now public figures who are speaking up, who've said that the medicine saved their life. And it's very difficult to, close all the leaks in that dike that are being suppressed by the media that are trying to do that.
Hey everyone, this lesson is on chloroquine and hydroxychloroquine's mechanism of action, more specifically on its antiviral properties against SARS coronavirus 2 or SARS-CoV-2, the novel coronavirus that causes COVID-19. So before I get into the mechanism of action, I want to lay down the setting as to where all this is taking place. So here is the plasma membrane of the host cell, and here is the host cell itself. Here is a lysosome, an acidified organelle that is responsible for recycling of nutrients and other waste products. And here is the nucleus that contains the genetic code. The first point I want to talk about here is that chloroquine inhibits endocytosis. We talked about how chloroquine is an alkalinizing agent. Well, we're going to talk about how it blocks endocytosis. And there's a paper that has shown that it can block Zika virus infections. So this is where we're going to start. So this paper talks about how it blocks endocytosis. So the SARS-CoV-2 virus is here, and this virus contains spike or S proteins on its surface. These S proteins allow it to bind to ACE2 receptors on the host cell. When it does actually bind to the ACE2 receptor, it can actually be endocytized into the cell, into an endosome. So it gets brought into the cell in this little endosome. That endosome will eventually transverse through the cytosol and fused to a lysosome, where the virus can enter into the lysosome and exit the lysosome, allowing it to infect the cell. So with regards to chloroquine, chloroquine can block this process through entering into the cell, and it can actually permeate into endosomes and the lysosome, allowing it to alkalinize the endosome and lysosome, which means that it can increase the pH of the endosome and lysosome, preventing it from being acidified. So those lysosomes and endosomes are not acidic the way they are supposed to be. So they become less functional or dysfunctional. It may also inhibit a proton pump on the lysosome. I've talked about this in previous lessons, that there may be some inhibition of a proton pump on the lysosome known as VATPase or vacuolar ATPase, although this is not entirely known at present. Nevertheless, due to the alkalinization of endosomes and lysosomes, endocytosis, the process of endocytosis, bringing the virus into the cell, is actually inhibited. It's stopped. And the fusion of endosomes to lysosomes is also stopped. So this whole process whereby the virus can enter the cell and get in can be stopped or slowed down. So the way this happens again is that chloroquine increases endosomal and lysosomal pH, and in doing so decreases endosomal and lysosomal functioning. So it decreases or inhibits endocytosis. So the second point I want to make regarding chloroquine's antiviral properties is that chloroquine is a zinc ionophore. There's actually a paper published in PLOS ONE in 2014 indicating and showing evidence that chloroquine can act as a zinc ionophore. That means that chloroquine can allow the entry of zinc into a cell. So how does chloroquine actually do this? So without help, zinc cannot enter into a cell. It essentially bounces off of the cell membrane. But with chloroquine, it can actually attach to chloroquine, and chloroquine can actually guide it through the plasma membrane, allowing zinc to enter into the cell. So why is all of that important? So the reason that all of that is important is that there's a study showing that zinc inhibits coronavirus and arterivirus RNA polymerase activity in vitro, and zinc ionophores block the replication of these viruses in cell culture. And this paper was published in 2010. So normally, when a virus enters, specifically an RNA virus, there's an RNA-dependent RNA polymerase, or RDRP. That RNA-dependent RNA polymerase will essentially make viral RNA. There's a lot of steps involved, but I won't get into all of those steps here. Nonetheless, this RDRP will produce viral RNA. It replicates the virus. However, when there is chloroquine and zinc around, these can cross over the plasma membrane together. Again, the chloroquine acts as a zinc ionophore, allowing zinc and chloroquine to enter into the cell. We talked about this before. Chloroquine has its effects on the endosomes and lysosomes, but this mechanism here more specifically has to do with the zinc. So as the chloroquine brings in zinc, the zinc concentrations in the cytosol increase. And the zinc can then act to inhibit this RNA-dependent RNA polymerase action. So it prevents that polymerase from making viral RNA. So it essentially stops the virus from replicating its genetic code. So it stops making viral RNA. So this study that I just showed actually shows that as zinc concentrations increase, viral RNA decreases. If you want to check out more on that, please check out that paper and look at some of their data. They show some interesting data. So again, as zinc concentrations increase, viral RNA decreases. That is the second mechanism. And the third point I want to make about chloroquine and hydroxychloroquine's antiviral properties is based on this newest article that is being published in April of 2020. So this article is entitled Structural and Molecular Modeling Studies Reveal a New Mechanism of Action of Chloroquine and Hydroxychloroquine Against SARS-CoV-2 Infection. So what does this paper show? So it all has to do with the cell membrane around the ACE2 receptor. There's actually something called sialic acid that is attached to the cell membrane that is usually pretty close to the ACE2 receptor, although it can be on much of the cell membrane itself. Sialic acid is essentially just a little piece of sugar, and the spike protein, the S protein on the SARS-CoV-2 virus can actually bind to the sialic acid as well. So these sialic acid residues actually can act like little receptors for the S proteins on the coronavirus as well. So what this paper shows is that chloroquine and hydroxychloroquine can actually bind to these sialic acid residues, preventing the S protein on the SARS-CoV-2 virus from binding to the sialic acid and essentially preventing the binding of the virus to the ACE2 receptor as well. So the way that chloroquine binds to the sialic acid, it actually prevents proper binding of the SARS-CoV-2 virus to the ACE2 receptor. So this is another mechanism by which chloroquine and hydroxychloroquine can inhibit the SARS-CoV-2 virus from actually infecting a host cell.
Hi everyone, I'm Connie Burton, and I just did a video interview with Dr. Robin Armstrong. He's been catapulted into the news because he treated his nursing home patients with hydroxychloroquine.
So it's been almost 20 years since I've been practicing.
Wow. Okay. So obviously, again, as I mentioned earlier, you're the medical director. I believe that's the correct title at this nursing home in Texas City, correct?
That is correct.
Okay. And so there was that nursing home was hard hit with coronavirus. And I believe it was 27 patients who were infected with this virus. Give us a feel for, give us the specifics of that. And how did you see this coming on? Why do you think there was a cluster? That kind of information.
Well, hey, I'll tell you. So there were actually 56 patients that were infected. So there were 56 residents that were infected with the coronavirus, and there were actually 31 staff members, 31 employees. And so total, there was 80-something patients, 87 folks in that nursing facility that were infected with the coronavirus. And so the Texas, so what happened initially was there were 3 staff members, 3 physical therapists that were infected. And so they were the first folks that we saw that had the coronavirus infection. And once that was discovered that those staff members were infected, then obviously those staff members are going to work with much of the building, many of the residents in the building. And so there was a concern amongst the Galveston County Health Department that we may have a lot of residents infected because of those staff members that were infected. And that's indeed what had happened. So the Department of Health in Galveston County came in and tested every resident, every employee, literally every human that was walking within 100 feet of that building got tested for the COVID-19 virus. And it turns out that there were 56 positive residents, 31 positive staff members. And so it really devastated this nursing facility.
Okay. All right. So let's get straight to the hydroxychloroquine. Now, at what point did you decide that you wanted to prescribe this medication for your patients? What made you decide to use that?
So what we saw was, all we had was the experience in Washington State where, 27% of those patients died. And we had the experience that we've seen in Louisiana. We've had the experience in some nursing homes here in San Antonio. They had a horrible outbreak where a lot of people died. And so we had the experience in different states, in Richmond, Virginia as well, where they had a lot of people pass away in the nursing homes. So, and then in Tennessee, where they just unloaded the nursing home, they just sent all those patients to the hospital. And so we didn't think that either of those were good options for our patients. We thought that was going to certainly increase their morbidity and mortality. Out of studies in China and studies in France, it showed that the mortality rate for this group of folks is 15 to 20%. And so if you have 56 patients that are infected, you can expect 9 to 10 of those patients to die. That's just what's kind of the statistics. And so, we obviously were not, willing to accept that. And so we thought, what can we do? We started looking at studies in China, started looking at studies in France, and we had heard about these as physicians. And in the hospital, I had used hydroxychloroquine and azithromycin on some patients in the hospital. We saw some good success, not success with everyone, but some moderate success. And so we decided, that these are safe medications. We've all prescribed hydroxychloroquine to our lupus patients and rheumatoid arthritis patients, and they had a good safety profile. They've been around for 80 years. And we also, everyone's taken a Z-Pack. Anybody's, that's essentially what azithromycin is. And then zinc is a vitamin, which we also treated them with zinc. And so there's been some studies to show that zinc is helpful. And so what we did was we decided that we would try and shelter these persons in place, keep them in their nursing facility, take care of them there. This is their home. This is what they're familiar with. And they're actually safer here and will do better here because the mortality rates for elderly people in the hospital is extremely high. And if they get intubated and placed on a ventilator, then their mortality rate is even higher. And so our goal was to keep them in place and to treat them as best we could there. Hydroxychloroquine and azithromycin and zinc were the only options there that we had. We figured that the safety profile for these medications was actually pretty good because they've been around for a long time. And so we thought, let's go ahead and start, treating these folks, on these medications, treating them a little bit earlier than has been done, and see if we can prevent these folks from getting worse. And so we only treated people who had symptoms, and so we watched them very closely. We rounded on them every day and managed them there. We had 2 physicians there. We had a nurse practitioner. We had a supporting nurse that actually works for me. And we didn't want to see the mortality of these patients go up so high. And so we decided that it would be safer for them, better for them to treat them in the nursing facility with these medications that were pretty safe and the only meds that showed could have some benefit. And so it's really interesting that people have made it a political discussion because I don't care about hydroxychloroquine either way. It's a medication. It's a tool. It's the tool that we had. And so we decided to use that to see if it would be helpful, knowing that our patients would be safe.
What it is that hydroxychloroquine does in the body itself.
The pathophysiologic mechanism for hydroxychloroquine is what it does. It's not a drug that actually kills the virus. And so it doesn't kill the virus per se, but what it does is it affects the virus's functionality. Okay. And so the proposed mechanism is hydroxychloroquine blocks some receptors on our cells. The way viruses live, the only way that viruses, because they can't live really outside of a host. And so they have to have a host cell to survive. And so the way they survive is they have to attach to our cells. And when they attach to our cells, they inject their DNA or RNA, depending on what type of virus it is. And then they basically hijack the cell. And so they start causing our cells to produce lots and lots and lots of viruses. And then they kill our cell. And then they continue to multiply and infect other cells. So what hydroxychloroquine does is it actually blocks the receptor on our cell, so it prevents the virus from attaching to the cell. And so it blocks those receptors, and it also alkalinizes the inside of the cell in combination with zinc, and that also affects how the virus attaches to the cell. So if the virus cannot attach to the cell, then the virus is not going to be able to survive. Once the patient is hospitalized and the viral load is so high, it's too late at that point, and hydroxychloroquine is not going to be effective in those patients. And so every study that has said hydroxychloroquine doesn't work is a study on hospitalized patients who have been in the hospital. And so that's how it works. And there was one study that showed that when you add azithromycin to it, then you clear the virus a lot faster. And so we really don't necessarily understand the mechanism of how azithromycin works with that. It has some sort of immunomodulatory effects that we really don't know. And then zinc actually it opens channels and allows for hydroxychloroquine to get inside of the cell and make that process even more effective. And so that's kind of how it works.
Let me ask you another thing. Did any of your patients have to be put on a ventilator? Did they have to get to the hospital? Did it continue on? Give me a little bit of information on that.
No, we had, so none of our patients had to be put on a ventilator. We had a few patients, maybe 2 patients that went to the hospital, but they were for actually unrelated reasons. One lady went because she was she had a fall and she was becoming very dehydrated. And then another lady actually went, and these are all patients that we treated. So I'm just talking about the patients that we treated.
Got it.
And we had another lady that went to the hospital for dialysis because it was a big logistical problem getting her dialysis in her regular center, because the regular dialysis centers weren't wanting to take COVID-19 patients because they didn't want to spread it there. And so the physician, the dialysis physician, the nephrologist just decided to leave him in the hospital to get dialysis during this episode until she tested negative for COVID-19. And so that was about it. We had some other patients we had one other patient that went to the hospital, but he was COVID negative when he left, and then he eventually became COVID positive. He was not someone who we had really gotten started on the medications, and he actually passed away. And so we may not have gotten him started early enough, I think, on the medications. And so he went to the hospital for a while and eventually passed away. But for our cohort group, we've actually had really good success. And we've had one that passed away. And so we've had, probably two. We've had two that died. One died of COVID-19. The other one died of consequences, and she was 102 years old. And so she's very elderly. But she actually passed away, but she passed away after, she had recovered from the COVID-19.
Is that right? So she recovered at 102. She recovered and then, oh my goodness.
3 more people have died from COVID-19 at a long-term care facility in Henrico County. The death toll at the Canterbury Rehabilitation and Healthcare Center now stands at 45 people. The nursing home has experienced one of the worst clusters of coronavirus in the country. More than 100 people at the center tested positive for the illness.
So we've been doing a lot of updates, and we've been going on now for about a couple of months here on COVID-19, and I thought we would do a review and a quick thing to make it practical. And so the question is, what am I doing for me and why? And what am I doing for my patients and why? And as some of you know, I'm a pulmonary and critical care and internist. I'm also a sleep specialist. And I've been seeing patients with COVID-19 now for at least a month. I haven't had any fevers, I haven't had any cough, and I've had a lot of questions out there about what it is that we should be doing. So I thought I'd go over what my regimen is and why I do it and go from there. And I think in the next video, we'll talk about what I'm doing for my patients and why I'm doing that. Okay, let's talk about vitamin C. Just realize that any talk that I give on vitamin C is going to be woefully underwhelming because there is so much good information out there about vitamin C, particularly in lung diseases such as ARDS and septic shock. And we've talked before on MedCram about vitamin C and its use in septic shock. Well, there's a study here that shows that vitamin C can shorten the length of stay in the intensive care unit in general. And this was a meta-analysis that was done back in 2019. There's also a really good summary on Healthline that asks the question, can vitamin C protect you from COVID-19? And of course, we don't have any evidence, particularly for COVID-19, on just about anything at this point, but it does go through the data, and it actually has very good resources about vitamin C and effects and what kind of research is out there depending on the endpoint that you're interested in. The bottom line that they come up with, they say that there's no proof that oral vitamin C supplements will help treat or prevent COVID-19. Of course, there's plenty of information that shows that IV vitamin C can help potentially in septic shock. That was Dr. Merrick's group out of Eastern Virginia. And also there is another study called Citrus Ali, which shows that vitamin C may reduce mortality in patients with ARDS. I say may because mortality was a secondary endpoint in that study. And by convention, they generally don't allow you to claim something that was a secondary endpoint. Nevertheless, do I take vitamin C? Yes. If I can get it in the stores, I take a supplement, but I'll also take a bowl of fresh fruit in the morning, which has lots of vitamin C and is probably more bioavailable. But you can get a lot of vitamin C from supplemental forms. I'll talk in another video coming up about intravenous vitamin C in patients for COVID-19 in the intensive care unit. That's a big topic. We've covered it already for septic shock, but we'll tackle it again. What about vitamin D? Well, there was this paper that was published in 2017, over 11,000 subjects in a meta-analysis of those who were on vitamin D supplementation and asked the question whether or not it could prevent acute respiratory tract infections. And the answer was yes. Here's a list of all the studies that they did the meta-analysis on, and you can see that the majority of these boxes were to the left of this solid blue line running down the middle here at 1, showing you that overall had a statistically significant p-value of 0.001, meaning that there was definitely a benefit taking vitamin D supplementation. But there were a couple of interesting side points to this. What they found was that if you treat 33 people with vitamin D supplementation, you could prevent 1 acute respiratory tract infection. That sounds like a lot of people, but that's actually not that bad in terms of pharmacology. Generally speaking, treating somebody with aspirin for a myocardial infarction is around the same number. They also found that it was better getting a daily or weekly vitamin D dose rather than a bolus dose when you were sick. And that those with vitamin D deficiency, which let me tell you is not uncommon, the number needed to treat was only 4. That is an astoundingly low number needed to treat, which of course means that the effect is very powerful. There was another study that was published from Trinity College Dublin looking at Irish people and whether or not vitamin D could help them. This is brand new data just published a few weeks ago. And this is known as the TILDA, or the Irish Longitudinal Study on Aging. What they found in this study was that in some people, vitamin D supplementation could reduce the incidence of chest infections by 50%. That's a 50. Now, of course, in Ireland, they have a lot of overcast days. I live in sunny Southern California, but I can tell you that a number of patients have vitamin D deficiency, and it's simply because we're inside all of the time. We don't get the benefit of being in the sun. So it really doesn't matter where in the world you are. If you're inside the whole time, you're not going to get enough sun exposure to get vitamin D. So do I take vitamin D supplements? You bet. And I actually take about 2,500 international units a day. That's about 62.5 micrograms a day.
You may be wondering what dose is right for you, and it's complex, right? So it depends on your age and a number of other factors. So my recommendation is to talk to your healthcare provider, and you actually may need to be tested and put on supplementation and retested for some of you.
I also take quercetin. And I have to say, the reason why I take quercetin is because of the early studies on hydroxychloroquine. Now, hydroxychloroquine, as we've talked about before, has a number of mechanisms that might inhibit the virus SARS-CoV-2 from replicating in the cell. One of those mechanisms is that it changes the pH of the endosomes that are needed for the virus to come into the cell, and that can prevent entry of the virus into the cell. Another mechanism is through a zinc ionophore. Hydroxychloroquine is a zinc ionophore. And as such, when zinc comes into the cell, that can shut down the replicase enzyme that the SARS-CoV-2 virus needs to replicate. Well, as it turns out, quercetin is also a zinc ionophore. Quercetin is found naturally in onions, capers, and other food products. You can get it over the counter. I take about 500 milligrams twice a day. And just as a side note, quercetin is being studied by a Chinese and Canadian researcher in China to see if it makes any difference with respect to COVID-19. Another supplement that I take is N-acetylcysteine, otherwise known as NAC, and this is another over-the-counter medication. And why do I do that? Well, it's because of this 1997 paper titled Attenuation of Influenza-like Symptomatology and Improvement of Cell-Mediated Immunity with Long-Term N-acetylcysteine Treatment. Basically, what it showed was when NAC was given 600 milligrams twice daily for 6 months, while it didn't reduce the chances of getting the influenza virus, it significantly attenuated the severity of the influenza-like illness, especially in elderly and high-risk individuals. And the difference was astounding. 79% of people in the placebo group had symptoms of the influenza virus, whereas only 25% of the virus infecting subjects under NAC treatment developed a symptomatic form of the virus. And basically what N-acetylcysteine is doing is it's helping out the liver in terms of reducing glutathione. Reducing is the opposite of oxidizing, so it's an antioxidant essentially. And it helps the liver in terms of getting rid of toxins. By the way, this is also the same medication that we give in patients who overdose on Tylenol, again, helping out the liver. So I take 600 milligrams 2 times a day. Okay, so I also take a zinc supplement. And if you want to know more about why, well, we just talked about the replicase enzyme from SARS-CoV-2, but you could also go back and look at MedCram updates numbers 32 and 34.
So I only take about 50 milligrams of zinc during these periods of time where I think I might be exposed to the virus. You have to be careful taking 50 milligrams of zinc a day because that is above the recommended daily dose of 40 milligrams, and there is some concern that taking doses higher than 40 milligrams daily might decrease how much copper the body can absorb. So it's not something I would do on a regular basis.